So welcome back to the class, and we are almost towards the end of our stomatology classes. Oh, this is the other one, and soon next week will be our last week, inshallah. Okay, so let's begin with the yesterday's slide, periodontal disease, the last part. Can you see now?
Yes, sir.
Okay, perfect. Let's start. Let's begin. Okay, so today we have how many participants? Oh, 14. Okay, so few of them are on leave for the 6 students right now are on the leave for the appointment. Is the appointment confirmation. Anyways, so let's begin by revising some of the previous slides. Okay, periodontal disease, as we already know, it's a chronic bacterial infection that affects the gum and the bones supporting the teeth. We already know this. And then we know that it involves the structure of the periodontium, breakdown of the periodontium or odontium, and then leading cause of tooth loss in adults. So it involves the structure of periodontium, and it breaks down the structure of periodontium and leads to the tooth loss, which is one of the leading cause of tooth loss in adults. Periodontal disease are the leading cause of the tooth loss in adults all over the world. Structure of periodontium, you already know: gaps, gingiva, alveolar bone, periodontal ligament, and cementa. And this is another showing types of gingiva: free gingiva, attached, and alveolar mucosa. Then some junction, such as mucogingival junction, cemento-enamel junction, and sulcus, gingival sulcus. This sulcus deepens down to make a pocket. So what happens in periodontal disease? We have healthy tooth, leads to gingivitis, including plaque formation and inflammation of gums, leading to periodontitis. If plaques is not removed, calculus is formed, and then calculus develops and hardens and form pockets around the teeth, and that the pockets deepen and cause periodontitis, inflammation of the periodontal tissues. And then it advances when the pockets deepen, the alveolar bone gets tissue loss, mucosal loss, and this will lead towards the apical area, will lead to advanced periodontitis. Then we had some gram-positive bacteria and gram-negative bacteria causing periodontitis. We already know ALS for gram-positive bacteria, Actinomyces lactobacillus streptococci, and then streptococci with two species were mutants and mitis, causing endocarditis. And salivarius was especially for the tongue, and strep salivarius, step, and geosus were colonizing the mucosal surface of the gums. And then we had few important gram-negative bacteria, including Porphyromonas gingivalis, causing P for periodontal, is a major periodontal pathogen. Actinobacillus, aggressive periodontitis, and treponema, causing A and UG. Other were Prevotella, Fusobacterium, Neisseria, Bellonella. This was Porphyromonas gingivalis. It's a gram-negative bacteria, has LPS, has endotoxin, and avoids opsonization. This is Vincent angina, also known as acute necrotizing ulcerative gingivitis, or sometimes acute necrotizing gingivitis, A and G, especially found in immunocompromised patient. And one of the important complication is septic emboli to the lung, may lead to pulmonary abscesses and empyema. And then another gram-negative bacteria. These were some bacterial species associated with their certain diseases. This is the distribution of bacterial type. more to the no more to the surface of tooth, gram-positive bacteria, and more towards the lower side, deep, we had gram-negative bacteria. Then we said that there are two main types of periodontal disease, gingivitis and periodontitis. Gingivitis were classified into acute, chronic, and acute ulcerative necrotizing gingivitis, or also known as French mouth. And periodontitis was chronic, aggressive, and necrotizing. Then we say gingivitis has many functions. Normally, the gingiva or gums look like pink, but when there is gingivitis, we have inflammation, swollen gums, dusky red or dark red gums, bleeding gums, halitosis, tooth pain, receding gums, and tender gums. And then we said, what were the risk factors? The risk factors were poor oral care habits, of course, smoking, old age, dry mouth, poor nutrition, deficiency of vitamin C, and conditions that decrease immunity like leukemia, cancer, HIV, certain drugs like phenytoin, hormone changes, medical conditions such as viral and fungal infections can cause gingivitis. So these were behavioral risk factor, and these were also some risk factors associated. Then we classified gingivitis generally, and there was another classification which was associated with some disease. There was generally, it was classified as mild, moderate, and severe. So we have 29 participants. Okay. And we have marginal gingivitis, drug-induced, and pregnancy-induced. Then we went to etiopathogenesis, where we said first, the patient will have a poor oral hygiene. Poor oral hygiene lead to formation of plaque. Plaque is not removed, it will harden and turn into tartar, and tartar will involve the local tissues, surrounding tissues, and will cause gingivitis. And the complications were, some of the complications were that gingivitis can lead to periodontitis itself, and then there was chronic gingivitis, which can lead to many diseases. And then was French mouth necrotizing ulcerative gingivitis, which is a severe form of gingivitis that is cause painful, infected, bleeding gums, and ulcerations. Then how to make diagnosis? We did some intraoral examination, extraoral examination, and then we measured the pocket depth by inserting a dental probe. Right? And then we performed dental X-ray, and we said that pockets deeper than 4 millimeters may indicate gum disease, such as gingivitis. And then we give some treatment, professional dental cleaning and dental restoration, ongoing care. Among professional dental cleaning, there was scaling and root planning. Scaling is when you remove the tartar and bacteria from tooth surface, and root planning removes the bacterial products formed by inflammation and discourage further buildup of tartar and bacteria and allows proper healing. So this is professional dental cleaning, scaling and root planning. You must remember these terms. So if next time you visit your dentist and you want some scaling and root planning, you can say these terms and he will be impressed, I hope. And then we have some prevention by brushing twice a day, floss once a day, mouthwash, using mouthwash, stop smoking and chewing tobacco, maintain a well-balanced diet, decrease your stress, avoid clenching and grinding your teeth, bruxism in children, and adhesion damage. Visit your dentist regularly for a checkup. If you have family history of gum disease, talk to your dentist. These were some good health practices, regular dental visits. And then a revision into the gingivitis. And after that, we say that from gingivitis, if not treated, if not taken care, it can lead to periodontitis. How it leads, let's see. So what happens is we have gingivitis and still not taken care of, the pockets become deepened. The structures are the alveolar bone and mucosal surfaces and the tissues, periodontal tissues, are more involved, leading to more deepened pockets, and then there will be periodontitis and advanced periodontitis. Okay, let's see. Periodontitis means inflammation of supporting tissue of the teeth, which were gaps: gingiva, alveolar bone, periodontal ligament, and cementum. Periodontitis is the extension of the inflammatory process, ongoing inflammation process. But was that gingivitis? So periodontitis is basically ongoing or extension of previously formed gingivitis. Okay, so risk factors were same as gingivitis, except gingivitis itself can lead to periodontitis. And then we had some primary and secondary factors. Primary factors itself are bacteria. Secondary factors other than primary, other than bacterial infection, is local or systemic. Local is when the plaque or the tartar is difficult to remove. When the tartar or plaque is difficult to remove, then the local bacteria will also be difficult to remove. So the plaque and the tartar buildup itself is creating more resistance and more difficulty for the periodontitis or the gingivitis to be healed or to be gone, right? So that's why local increased resistance can be in terms of bacteria, that the medicine is not this resistance can be anything. For example, some bacteria resistance to some to show some resistance to antibiotics, the resistance of the patient itself, or the resistance of the substance to be removed. Yeah. And then systemic, certain diseases, certain conditions like diabetes or compromised patient, immunosuppressant, even the drugs can help to contribute the buildup of plaque, tartar, and bacteria, leading to periodontitis. This shows how bacteria from periodontal tissues lead to circulation and then can go to distal sites and form these and can cause these disease. Stages of progression: healthy gums, gingivitis, which is plaque, inflamed the gums and bleed easily. Then this, when the beginning of bone and tissue loss starts. So beginning of bone and tissue loss starts, mild periodontitis. More bone and tissue destruction can lead. This stage is known as moderate periodontitis. And then there is extensive bone and tissue loss, and teeth may become loose and very easily movable, and it can lose anytime. This is severe periodontitis in simple medical terms. So we start our lecture from here. Okay, still 29 students. Okay, so what are the characteristics of periodontitis? Healthy gums are firm and pale pink and fit snugly around teeth. So they fit very tightly and very easily, that we have no gaps among the tissue and the teeth. But when there is, and symptoms of periodontitis can include puffy gums, also seen in gingivitis, bright red, dusky red, purplish gums. Bright red, dusky red, we also know that it's also seen in gingivitis. That's easy to remember. I'm trying to make you to see the common things in the both types of periodontal diseases, which are gingivitis and periodontitis, so that you can remember most of the characteristics and reproduce at the time of your exam. Gums that feel tender when touched. Okay, maybe gingivitis, of course, it also has, because that's also inflamed. Gingivitis gums will be also tender. Gums that bleed easily, gingivitis also have, same as periodontitis. Gums that pull away from the teeth, recede. You remember, receding gums were there in gingivitis, so here we also have receding gums. So gums that pull away from the teeth. So the teeth area is more exposed. When the gums will be swollen, they will be pushed upwards away from the teeth surface, and the more teeth from the apical surface will be visible or apparent. That's known as receding gums. Receding gums. Okay, perfect. Then making teeth look longer than normal and more, exposing it to the bacteria and tartar and calculus, more exposure. New spaces developing between teeth, interdental spaces or sulcuses or grooves. Pus between the teeth and gums, they can be pus, you can see. So now this part is unique to this. Pus between the teeth and gums is unique to periodontitis. Bad breath, halitosis was also seen here, also seen there. Loose teeth, this is also specific to periodontitis, because how to say, gingivitis was not so aggressive or not so severe to cause new spaces development, pus, loose teeth, and painful chewing. Painful chewing will also be seen. So we can say new spaces, pus, and loose teeth. are the extra features which can be found in the periodontitis, but we cannot find in gingivitis. This is how you remember. I'm trying to make you relate so that you can remember. Okay, now this is also basically histoimmunology, you can say. This is histoimmunology, how the healthy gum are different from the periodontal or disease gum, and then how from the cemento enamel junction they go down and cause the inflammatory response in the cell. So this is alveolar bone. Let's just make some basics of this. Outer side tooth enamel, and then we have epithelial cells here, and then we have alveolar bones, and this is the space. These are the resident cells found in the space. And then here at the below we have legend. Legend means what are these cells, the names of these cells, and this is how they respond. All you need to know is interleukin 8, interleukin 6, interleukin 1 alpha, 1 beta, which is of course here, and tumor necrosis factor alpha. Again, tumor necrosis factor or tumor necrosis factor alpha, interleukin 1 alpha and beta, and then 6 and 8 interleukin are responsible for the driving responsible for driving the chemotaxis and the basically the inflammatory response. What is chemotaxis? The movement of cells towards the inflammatory cells or towards the bacteria. Chemotaxis. Okay. What is diabetes? Anyone? Diabetes. 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 Anyone knows? Do you remember white blood cells? When there was inflammatory response, some white blood cells get out and squeeze themselves out of the epithelium, out of the capillary membrane.
Yes, sir. And sir, at times infiltrate some organs as well.
Sorry, I didn't hear you.
Exactly, sir. Basically, sir, sometimes, sir, these white blood cells, especially T lymphocyte, like sir, they move from the capillaries and the venules, and so they infiltrate some different organs. Like let's say, for example, they go into spleen and some areas. So this is also the part of the diabetes.
Exactly, the movement of white blood cells out of the capillaries, out of the capillary membrane, they squeeze themselves out towards the chemotactic substance or the chemical substance where they are getting signaling from. So this movement is known as diabetes. Perfect. Okay, thank you for your answer. So now we go towards periodontitis types. So we have 3 types: chronic, aggressive, and necrotizing periodontal disease. Okay, let's see. Chronic periodontitis, the most common type. So this is the chronic one, is the most common type, affects mostly adults, though children can be infected too. This type is caused by plaque buildup and involves slow deterioration and causes destruction in the gums and the bone and loss of teeth if not treated. Nothing new, just a word chronic is added and it goes slowly and prolonged. That's it. This most common type, it's found in the adult. Plaque is built up, tartar is formed, slow deterioration, destruction in gums, bone loss, everything is periodontitis, but it's going slow progression and prolonged for a long time. Chronic periodontitis, nothing new, right? And then we go aggressive. Okay, so usually begins in childhood and early adulthood. So chronic is found in adults and aggressive is found in childhood and affects only a small number of people. It tends to affect families and causes rapid bone and tooth loss progression if untreated. So it runs in families. It's aggressive. Necrotizing periodontal disease is characterized by the death of gum tissue. because necrosed, you know, necrosis, right? Necrosis is the death of the tissue. So death of gum tissue, tooth ligament and supporting bone structure. So whole periodontal tissue got necrotized, which include gum, which include ligament. Which was that ligament? Periodontal ligament. And then supporting bone is alveolar bone, right? And then necrosis, wherever there is necrosis, the main one of the reason is blood supply, lack of blood supply, resulting in the loss of tooth. It's very easy to remember. If you know the names, you can make up the information required. You can make up a medical story using medical terms, right? So chronic periodontitis, aggressive periodontitis, and necrotizing periodontal disease. Now we have non-surgical treatment and surgical treatment. From non-surgical treatment, if the periodontitis is not advanced, it's like chronic, is not advanced, scaling can be done, root planning can be done, and antibiotics can be given. You know what is scaling from here, previous slide. You know what is scaling and what is root planning. Scaling removes tartar and bacteria. Root planning removes bacterial products and also towards the root side, apex side, and discourage further buildup of tartar and bacteria, and also allows proper healing. This is scaling and root planning, right? No need to revise. You should know that. And antibiotics, what we can give is topical or oral antibiotics can help control bacterial infections. Topical antibiotics can include antibiotics, mouth rinses, or insertion of gels containing antibiotics in the space between the teeth and gums or into pockets after deep cleaning. Why we need antibiotics? Because periodontitis had some pus and it an advanced infection than gingiva. The infection is now not constrained or is not consisted only of gingiva. It has expanded beyond the gingival borders and reached other tissues of the periodontium. That's why we need some topical or oral antibiotics. And however, oral antibiotics may be necessary to completely eliminate infection causing bacteria. These diseases, we very easily ignore them, but we find them in daily life, in daily medical checkups. There are some patients, and even by ourselves, some of our classmates or some colleagues, or however some of our family members, our relatives, they will ask us, okay, do you know I have tooth pain, I have this, I have that. Maybe a little, you give some time to them and see intraoral or extraoral, give them some examination, give them some time. Maybe you can diagnose. You don't have to say, oh, go to dentist or whatever, right? You know some things. Maybe you can say some, oh, you can go for scaling, root planning, or your gingiva looks swollen, oh, but they are not deep pockets, so it's not reached to the periodontitis, odontitis, so it's not severe, so you can use mouth rinse, take care of your. So that's why we need to remind this is not a minor subject. Whoever is treating this as a minor subject, we are learning a lot from this subject. Like, for example, we revised our history taking. That history taking was not only for dental history taking, it was an overview, a review for other history too, right? A review. And then your anatomy, oral anatomy, you studied a lot about the muscles and the nerves. That was also a revision. So everything is relative and connected. And these infections are looking like minor, but they will help you to know something extra, right? So pay attention. So stages of gum disease: on the right side, we have stage 1, gingivitis, stage 2, slight periodontal disease. So how to differentiate gingivitis from periodontitis? This is just up to the margin of the gums. The pockets are not deepened. And here, when there is periodontal disease of the periodontitis, when there is periodontitis, then we have some pus. We have an advanced looking, not simple gingivitis looking, not only the gums. We have an advanced looking situation. So we know that this gingivitis has already proceeded or progressed to periodontitis. Then we have slight, moderate, and advanced periodontal diseases. You can study here. These pictures are basically revised again and again, but for your own good. When you read the same thing, but with different wordings and from different sides, different pictures, different diagrams, then it will be a revision and a clearance of the concept too. Okay. And then we have surgical treatment of periodontitis. We have flap surgery, soft tissue grafts, bone grafting, and tissue stimulating proteins. I will love this question. In advanced periodontitis, treatment may require dental surgery, such as flap surgery, also known as pocket reduction surgery. So, as we already know, from gingivitis to periodontitis, the pockets are getting deep and deep towards the apical and root side. And when the pockets become deep, you know the tooth become loosen, easily movable, and can get out, right? So that's why we need pocket reduction to make sure the teeth stay in the alveolar bone and to reinforce the teeth inside the alveolar bone and around the tissues. The periodontist makes tiny incisions in the gum so that a section of gum tissue can be lifted back. So what a periodontist do is they make tiny incisions, cuts in the gum. When they put a cut in the gum, this is a mucosal layer, it will open a little, you know. What happens is when you give a cut incision here, this will loosen a bit. As you remember, if you have somehow used a knife and give some incision to a piece of meat, when you give it a cut, it will open itself, right? It will open itself. So for example, this is a where is the mouse? Come on, don't do it, please. Come on. Okay, thank you. So we have a piece of meat, right? And then when give it a cut from the center, it opens up a bit. Opens up it, right? The periodontist makes tiny incision in the gum so that a section of gum tissue can be lifted back. Use your imagination, and then exposing the roots for more effective scaling and root planning. What it will do is it will expose the roots. We will get a more approach towards the roots and apex side, and we can get an effective scaling and root planning. So the purpose of flap surgery and pocket reduction surgery is to get an effective scaling and root planning. So this surgery, as it looks very modern and this, but still trying to go to the basics of the root cause or the root cause of the disease, which were plaque, tartar, and bacteria. Right? These build up were causing gingiva and periodontitis. And then we are doing flap surgery to do scaling and root planning for these plaque, tartar, and bacteria effectively. I hope now you remember. So we have periodontal flap surgery, the most versatile and commonly used surgical approach in periodontal treatment. Stomatology is not basically a subject of medicine. It's a subject under surgery and allied subjects. Medicine allied not, surgery and allied yes, right? So a lot of treatments will be asked in exam about the surgical treatments. Okay, so never skip a surgical treatment. The most versatile and commonly used surgical approach in periodontal treatment. Okay, a periodontal probe has revealed a deep area. This is periodontal probe and has revealed a deep area of tissue detachment or a pocket. So with this dental probe, with this periodontal probe, we are examining the depth of the pockets. After that, the first step is to clean and disinfect the tooth. What is this known? We are doing scaling from the surface, and then we create a flap by giving a small incision through which the diseased area are accessed or exposed. So now the diseased area is exposed, right? First we did scaling from the surface, then we give an incision. So because of the stretch of muscles, they move towards side, and we have this area exposed, and now this area can be accessed. This is exposed, and we can do scaling and root planning here. What is scaling and root planning? Do not make me revise. You know, scaling is the removal of plaque and tartar. Root planning is not only the removal of deep plaque towards the apical site, but also helps in further avoiding the buildup of tartar, plaque, and bacteria, and allows it to heal itself. Perfect. And then after that, we give a suture after cleaning, after deep cleaning. But we give, you can see here, stitches, or you should say sutures. We give a sutures to the, we give here incision, right? After incision, this part went here, this part went here, and you can see these parts are separate. After that, we will bring them together and give it a suture so that the tooth can stay in this place, and these mucosal surfaces almost overlap, almost are parallel to each other, and after that they will heal. So this inflamed tissue and deep periodontitis is healed. Okay, perfect. I hope you understand. I hope you can reproduce this answer in the exam. Second is soft tissue grafts. What do you mean by soft tissue grafts? Grafts, when there is a recession in gum line. What do you mean by recession in gum line? When the gums are swollen, they will expose more area of the teeth. They will expose more area of this side. The gums will move towards this side. Receding means going towards opposite sides, such as your teeth or teeth surface get more exposed. Swollen gums recede themselves so that the area get more exposed, and this exposed area which previously receding gums, we need to have more. So when there is a recession of gum line, we need to have some of the damaged tissue reinforced. We need to put them back to the place. This is usually done by removing a small amount of tissue from the palate or another donor source and attaching it to the affected side. So we are taking a small tissue, mucosal surface, from where? From palate or any other source. So just remember palate, and then attach. So we are doing soft tissue grafting. How beautiful, right? Now you are plastic surgeons too. So this can help reduce further gum recession and cover exposed root. Why we need to cover exposed root? Because when they are exposed, they are, what can happen? Further plaque can deposit, further tartar can build up. The plaque itself hardened to make tartar, and then there's a party for bacteria. We don't want bacteria to party because they create caries, they create acids, lactic acids, and cause periodontal disease. That's why we don't need plaque. We don't need these receding gums. So that's why we take a tissue from the palate, bring it here, and graft it. Soft tissue graft. Okay. So then there is bone grafting. When the bone is destroyed, we use bone to bring it back. This procedure is performed when periodontitis has destroyed the bone.